I'm going to go ahead and call the subcommittee meeting of Appropriations Health Subcommittee to order. We're a couple minutes late starting, but there's several things going on, and we'll have some more members that'll probably be coming in and out. There's other meetings going on and some budget hearings and things like that. But in respect for your time, I'd like for us to go ahead and start. So we're going to call the meeting to order, and we'll get started. And the first person we're going to hear from is LaShawn Hughes with the Georgia Composite Medical Board. So, LaShawn, if you would, come on up, please.
And I'm Dr. Alex Gross. I'm a board member.
He's here to answer all the tough questions. So this is for the Georgia Composite Medical Board, FY21. Just to tell you something about the board, we are the licensing authority for physicians, PAs, respiratory, acupuncture, orthotists and prosthetists, perfusionists, cosmetic lasers. We are the approving authority for APR-oriented prescriptive authority. So we have a new profession that came on board from the last legislative session, which is genetic counselors. So last Thursday, the board met and we issued the first licenses for those. So we issued 14 new licenses for genetic counselors. It's our first round of people coming through. So we have probably 100 applications that are pending, but that new group has started licensure. We have 16 board members, all appointed by the governor. 13 are physicians, 11 MDs, 2 DOs. We have 2 consumer members who are non-medical. We have 1 physician assistant, and the board has 31 members, has a 31-member staff. Want to talk about licensure? You want to share? Okay, so you'll see the pie chart of licensure. So during FY 2019, we received 4,343 initial applications. We issued 4,819 new licenses. The numbers are different because people apply in 1 year, don't complete it, and finish up in the next fiscal year. It's driven by the applicant, so as long as they take to get their application in, then that's how long it takes to get licensed. The board renewed 24,764 licenses, and we generated from applications $6.4 million. So you'll see our different categories of licensure there. Enforcement of our board rules. So we received 2,621 complaints on FY19. We have them by category, and you'll see those, and we'll be happy to answer any questions for that. We also have our Director of Investigations, Jonathan McGee, here with us as well. So the board is concerned about the opiate prescribing, and Dr. Gross is our rules chairman. So the board passed a rule in 2018 to require every physician that has a DEA and controlled substances to be required to have at least 3 hours of training for everyone, each physician. In FY 2019, we were given $2.9 million, but you can see from our renewal fees, application fees, and fines, and other administrative fines, we returned $7 million back to the budget this year, to the general treasury. Now we get to our budget line. You want to do budget? You want to do this one?
You go ahead.
Okay. 17.17 and 17.1 is increased funds. This is the governor's recommendation, $1,000 pay raise for people that make under $40,000. 17.17.2, we eliminated the funds for medical director's position. This was put in last year, and it was vetoed. 17.17.3, eliminate funds for 1 contracted assistant medical director for $25,000. 17.4, reduce the funds for travel by $5,000. 17.5, we reduced the funds by $120,471. We implemented a new computer system so these were implementation costs now that the system is live. So we've offered up that reduction for a total of $281,045. I'd be happy to answer any questions.
Okay. Representative Taylor has a question.
Thank you, Mr. Chairman. At 17.17.5, can you give me an example exactly what you're going to do to have these efficiencies and what the system now will be doing and how it's going to work?
So we had an outdated licensure system. The computer company that we had originally bought the system from no longer supported the application. So we had to purchase, the state owns system automation. So we purchased a contract, the application and entered the contract with the new system for licensure and enforcement.
I understand that. So it's going to be more efficient?
Yes,
So you
ma'am.
will need less people? Is that where we're going? Again, I kind of want to see where the efficiencies are exactly. Are they in timing? Are they in mailing? Is everything, you don't print something, they download? I'm looking for exactly what it is.
Right. We would not recognize an efficiency for that, other than we have a new system. You can download information, we can upload information into the system, but we will continue to mail. We're still mailing out ID cards for physicians. Other boards have stopped doing that, but we still do that for all of our licensees. So we can print the information directly from our system now and print the ID cards in our office. So that's one efficiency.
Okay, it's just, it's a lot of money to show inefficiencies, and that's why I'm wondering, is it involving staff or less mail or less paper, or what exactly were the efficiencies?
The board looked for the recommendations for the budget cut, and this was the place that we had to find an efficiency other than staff.
Okay, thank you.
I do. Thank you, Mr. Chairman. My question is about the medical director's position that was vetoed, the services or the activities that that person was going to do. How are you handling that?
So we, at different, I've been on the board for almost 14 years, and during different times during the past 14 years, we've had full-time medical directors who were full-time staff. We've had part-time medical directors, and really the main thing was that the full-time medical director was available to review complaints as they came in, and would take a lot of the work off of the plate of individual board members. So now most of that work product has shifted to the volunteer appointees of the medical board who have taken up the slack for us not having a designated medical director.
Thank you, Mr. Chairman.
Sean, I've got a couple of questions for you. I was looking at some of the information you passed out here. You received 4,300 initial applications, issued 4,800 new licenses, and renewed 24,000. And how many people do you have in your shop over there?
We had, how many people we licensed?
No, how many people do you have working with you? Speak into that mic, if you would. I guess I can
It's,
get
we have 31, we have a staff of 31.
Okay. And to follow up on what Representative Hughley said, this committee recommended last year that we fund that medical director position because we felt like that was something that was worthwhile with the opioid crisis that was going on, being able to handle complaints in a more timely fashion and this sort of thing. We were disappointed that that didn't make it through. And it's not like, I'm looking here, if I read this right, you're generating from, let's see here, so $7 million.
Yes, sir.
And you're budgeted a little less than 3. So you're a pretty good profit center for the state there. We appreciate that.
We try.
But we certainly want to make sure that you have the necessary tools that you need. And I guess my question is this: do you feel like operating the way you are now. Doctor, do y'all have sufficient staff, and are you able to turn around complaints as quickly as you would like to, or licensing requests as quickly as y'all need to in a timely fashion, or what?
So I think that the medical board kind of sort of is a great representation of the old adage, never have so few done so much with so little. I think that the board is doing a fantastic job taking care of the citizens of Georgia, which is what our mission is.
Right.
I think that certainly our lives would be made easier if we had some more resources. A lot of other state medical boards basically are funded by the proceeds that they take in. So, our neighbor to the north, North Carolina, and our neighbor to the west, Alabama, basically what happens is that the money that the boards collect, that is their operating budget. So I don't want to, on the one hand, make you feel like we're not doing what we need to do to take care of people. We are. But certainly with increased resources, it always makes people's lives easier.
Right. Well, if someone were to come to you and say, what can we do to help you make your department be more efficient and more effective in carrying out your mission, what would be your top 2 or 3 requests or items that would be the most benefit to you?
So would you say it's mainly personnel? So, we can always use more investigators. We can always use more folks who actually are the ones who are reviewing and processing the applications. And our turnaround time is really, really good. We've really kind of gotten it honed down to a point where we're getting people licensed in a timely fashion. But I would say that those would be the 2 big areas. When the board talks about what would help us, having more investigators, having more people to push the paper.
Right. Well, is the medical director position, would that still be a priority?
Yeah, having a medical director would be great, because the board meets one day once a month, and then you have somebody basically who is there all the time to look at files, and certainly if there's something that requires a more urgent response, then you've got somebody there to jump on top of that.
By having someone there to review those files, other than just that once a month when you meet, if there's an issue that arises that seems to be critical, you're able to go ahead and act in a timely fashion with that?
Yes, sir. Yes, sir. So what happens is that basically the state law is that if we're going to convene an emergency meeting, we just have to give the public 24-hour notice. And that happens, I don't know, I'd say maybe half a dozen times a year where we have to have an emergency meeting because there's somebody who's a danger and we need to act on that quickly.
Right. Okay. Any other comments or questions from the committee? Well, thank you very much. Appreciate you being here, and thank you all for what you do for us.
Thank you. Thank you all.
Okay, next on our agenda, we're going to hear from Dennis Troughton. He's the director of the Georgia Drugs and Narcotic Agency. Come on down, Dennis.
Mr. Chairman and members. All right. Georgia Drugs and Narcotics Agency, we are the enforcement arm for the Georgia Board of Pharmacy. That is our primary function as regulatory investigators, but we also are investigators for anywhere in the state that has prescription drugs. So we actually work with local law enforcement frequently around the state. We work with federal and other federal agencies and state agencies on those type of investigations. The bulk of our work is the enforcement and oversight, though, of pharmacies in the state of Georgia and for the Board of Pharmacy. We start at 17.18 on the tracking sheet, and the first at 17.18.1 reduction of regular operating expenses, and our total budget's 2.4 million, but the regular operating expense is one of the areas that we're going to attempt to cut is in travel, and our agents are spread out. I have 10 agents that cover the 159 counties, and they live in their territory. So they travel, I believe our largest territory is 29 counties. And then we have one that covers Fulton County. So we divide them up based on the size of the number of pharmacies in those territories. But so some of that kind of travel we can't cut, but what we were attempting to do is reduce that travel through our training and have our agents trained, attempt to train close to home, and online when they can and when it's permitted by post. We have all of our agents are post-certified officers, as well as, including myself and deputy director, are post-certified officers as well as registered pharmacists. So we are attempting to, I think we can do some cuts there, and our travel is one of our main areas we're going to attempt. I have 3 office staff members, and so we don't have very large office space and supplies, et cetera, if you would, but certainly that'll be an area we'll be looking to be more efficient in. The second item there, 17.18.2, that was a data management system. Our agency that's been around since 1908, but does not have a data management system of our own, if you would, that we can keep track with investigations, keep track of regulatory issues, keep track of licensing, and that was the last year's purpose of that, and that y'all saw fit to provide, and that the languages considered non-binding, so forgive me, it boiled down to we didn't get it. So that's where that money is coming back out. Reduced funds for personal services, and that is 2 places. We had a funded but unfilled administrative position in the office and for office staff, and so we will eliminate that. We have a agent who had retired recently, but has worked for us part-time to fill some gaps and travel around the state and assist other agents, and again, because there's that travel involved, and we will likely be decreasing his services and saving some money there, doing some cutting there. As far as the telecommunications, primarily on that issue, we had a number of tablets and Surface Pro items that our agents had been using, and they have laptops, but we had obtained I believe it goes back about 4 years, some Surface Pro tablets that made it easier for them. You can imagine they're in and out of the car all day, going into pharmacies, et cetera, doing inspections. We're just not renewing those tablets. They will be using their laptops. They can do, and I'm not a computer guy, but I certainly know they can do the same things with those. That was a item that was more of an item when we got those to make it easier on our agents to be going in and out of their car every day and in and out of facilities and utilizing those, and did help to get the information back into the agency quicker onto our own server. That's what we deal with now. We have our own private server within our agency. So that, folks, is the summary of our budget there, and if I can answer any questions, I certainly will.
Do we have any questions from the members of the committee? I've got a couple for you.
Yes, sir.
You said you had 10 agents.
10 full-time, yes, sir.
Right. How about total number of employees?
10 agents, myself, deputy director, and 3 office staff. So, and so 15 full-time.
15, okay.
And the 1 part-time that had been helping us.
Okay, had a question from Representative Hughley over here.
Thank you, Mr. Chairman. I wanted to ask about the elimination based on the governor saying that it was non-binding. So does that mean you're not getting a data management system, and what are you doing instead?
That is what that means, that we did not get that, and so we are continuing what we have been doing all along, and that is working with, I don't mean to sound real old-fashioned, but literally Excel spreadsheets are our primary data resource for just being able to store data and sort and find and hunt and peck. All of our reports and everything else are actually still on paper. So every report that comes in from my agents is in a file room, yes ma'am, in the back of the office.
Wow. Thank you, Mr. Chairman.
Okay. Anyone else have a question? Dennis, I got another question for you.
Yes, sir.
Approximately how many pharmacies do you inspect, or in the state that you're required to inspect?
The retail, I believe, is about 2,500. That sounded right. In a couple hundred hospitals, and then there are several hundred more clinics, that
Right.
type thing. And then we do wholesalers as well, inside and outside. But I would say probably close to 3,500 maybe
Okay.
facilities, that we're talking about.
How about the technicians?
I believe we're up to about 22,000. And they started registering those in, I believe it was 11.
Right.
That they started registering those. I believe our pharmacists are around 15,000.
Okay. And you're doing all of this with about 3 people in the office with some outdated computers. Don't answer that.
Yeah.
Don't answer that. No, but seriously.
And they do a great job, though, by the way,
Yeah.
the people I got.
To follow up on what
Please
Representative
don't do
Hughley alluded to, this committee recommended to our side on the budget that we put in this data management system, and that $184,000. That was the initial installation of that, and the ongoing cost of that would be considerably less. This included the system being installed and everything, right?
Yes, sir, that was the startup cost, and including that person for a year.
Yeah.
And then, depending on the type person in the system and what expertise they would need, the ongoing cost would have likely been much closer to 65 benefits and everything.
Right. And now, at one time, a couple of years ago, we helped you a little bit bump the salaries up of some of your inspectors.
Yes, sir.
And you alluded to this. Your inspectors are post-certified and pharmacists.
Yes, sir.
And at one time, if you were a pharmacist working in a state hospital, your salary was more than a pharmacist who was post-certified and carried a gun and made arrests and worked for you. And we've been able to work on that some. And now you also mentioned that you had a position that had been vacant part of the time. How difficult is it for you to fill these positions, and is it a function of the ability to pay a salary to these folks, or what?
At this point, there was about 3 years there that y'all helped us, literally. You folks in the legislature and the governor's office helped us to bring that salary up to a much better level, because for years at one point we had 14 agents, but then there was a time period when I was an agent out on the street working, we were down to 7. Mm-hmm. And as we've come back, this is the first year after what y'all did for us 2 years ago that we were able to fill all of our agent positions. This is the first time since I've been there in '98 that I started, we were able to fill those agent positions. So I believe our salary, when it comes with the benefits that it comes with, I don't believe that is the issue.
That's
so
better.
we've filled the funded positions we have for the first time in 22 years. So that part of it, could we always use more? As the medical board folks said, you bet we could. But I don't believe what the state offers now for the agents, that I don't believe is a problem anymore. We've been able to fill all those positions.
Well, would it be a fair statement to say that if we were able to modernize your data management system like we had talked about, you felt like that would really enable you, almost like having an additional agent, just because of the efficiencies that your staff could work at and not have to write everything on paper now, and it would be electronic and that sort of thing?
I mean, yes, sir. Everything is going that way, of course, and we're not going to have all the paper anymore. But without a doubt, to be able to have a safe and secure, we've got our own little server in there, but to have a safe, secure network. My agents cannot tap into our server from home. So it's a call to hey, can you see if you have this and scan it in and send it to me?
Mm-hmm.
So without a doubt would modernization, I feel like absolutely would add a person or two to our efficiency, to our security. I mean, I think there's a lot of advantages to that, without a doubt. But we will trudge on with what we've got until we get a little more modern.
Great. Got a question, Representative Hawkins?
Yeah, with the Surface Pros, I've got one. You can actually handwrite to text, and then you could email the report to the office rather than carrying a piece of paper, right? And then you wouldn't have to have file cabinets. You would be in your server stored.
I do believe you are accurate, sir.
So it would help if you had those Surface Pros back, wouldn't it?
Yes, sir.
Thank you.
Thank you very much. I'm trying to remember the total cost of this, bringing your agency into the 21st century. Was this 164,000 was the startup cost?
184, yes, ma'am.
184, and then in the next year's budget, how much would it be?
Really, the person and the upkeep, I believe we at that point figured somewhere between, depending on the system and what level of, not perfection, that's the wrong word, level of skill we would need to maintain the system, probably anywhere from 60 to 80, depending on that system, as a yearly type. Part of that being the upkeep, the $20,000 a year to upkeep and maintain the system, and then the person to maintain it for us.
Well, we know systems aren't magic, but it must not be a job. It's a lot of fun if you have to do all that paper and.
I love my job, though.
Well, I appreciate the work.
Just in case.
I really appreciate that your agents are willing to hang in there. It's important work. We all know it's an important part of our safety net. So we need to figure out a way to do something about that, Mr. Chairman.
I got you. Any other questions or comments from the committee? Thank you very much.
Yes, sir.
Thanks
Thank
for being
y'all.
here.
Let
Thank you
me
for
tell
what
you,
do
because
for
our
us.
agents do a great job for what they do. I love this analogy before, but 10 folks covering that many pharmacies and all those drugs in the state of Georgia, they appreciate what they get, and I do too, but they have a great staff, so I appreciate y'all's time.
Great. Thank you. All right. Last on our list, the Georgia Trauma Care Network Commission, Liz Atkins, Executive Director.
Good afternoon. Thank you, Mr. Chairman. And I'm by myself again today, solo, round 2 of my tour by myself, and new in this role, as you all aware. The Georgia Trauma Commission is a 9-member commission that is primarily tasked with overseeing the flow of funds through improving the trauma system as a result of SB 60 and now official Georgia Code 3111-102. So what we'll talk about today is just kind of what we're doing with our budget, so you can see some of the changes. Our primary source of revenue is the super speeder funds, as you can see on slide 2 and then on slide 3. And we're ever so grateful to be supported by those super speeder revenues. And as you know, we every year ask for an amended budget to include the balance of what we don't get, because the super speeder revenues are in the 22-23 million range, and our budget typically runs in the 15 to 16 million range. And we have been getting amended since FY17, and I know that this committee has heard a lot of those improvements, most notably or most recently through the Stop the Bleed schools, now school bus, and emergency department initiative. But we do now have a secondary source. On slide 4 is our fireworks excise tax, and we just started to get revenue from that from what was collected in 2018. So that went for FY 2019 budget for us, and so there's about 2 years now of fireworks excise tax. And then the last time I spoke, I believe, to this committee was on slide 5, was the amended budget. Our ask was for the 6.7 million. We did get the 4.7, so we are going to go back. Our budget subcommittee actually meets tomorrow. We're going to talk about this as well as the FY21 budget, about where we're going to par down from this. And just a quick review of what, on slide 6, of what our main initiatives for 20 and 21 are, is we really want to complete, we only have about 5 counties left for the school Stop the Bleed program, but we are also installing Stop the Bleed kits on all the public school buses. That's going to take a little bit longer, but Stop the Bleed should be completed by the end of this school year. And in addition, we want all emergency departments across the state to have bleeding control kits, because that's not the case right now. We also want to increase our funding support. We'll talk about in a second, but we have a funding formula that basically for our 4 levels of trauma centers, 1 through 4, the 1s and 2s are set at a percentage of what the funds are. The 3s and 4s right now get a stipend, and our concern is, and the more I'm traveling around and hear from these folks at these centers, is that the level that we're funding them at is not really injecting enough into them to help really make a difference. So what we have to do is really try to quantify what are really the needs in the rural areas and the rural centers, and what can we do to really help that. Part of that is establishing a statewide advisory committee. We are regionalized, and the commission oversees that. So each EMS region has a regional advisory committee comprised of hospitals, EMS agencies, and we want to have like sort of a statewide committee that all those committees can sort of roll up under. So obviously all that will be voluntary. But perhaps our biggest task is that we'll be preparing for an upcoming American College of Surgeons system consultation. So the American College of Surgeons is the entity that sort of oversees trauma quality, not only in trauma centers, but trauma systems. In fact, right now they're rewriting the rules and regulations. Dr. Ashley, our board chairman, and myself found ourselves on a couple of the committees there to participate in that work, which is very exciting. So hopefully the rules or the new book will be put forward before we get our system consultation. But that largely drives what our initiatives are. We haven't had a system consultation in over 10 years, so we really need to kind of see from an outsider's point of view, what some of our major opportunities are. And then on slide 7 is really the proposed budget, and there's 2 groups you can see there on the left of main budget areas. Commission operations consists of myself, a finance officer, an office coordinator, and a deputy director. The system development, access, and accountability is really that regionalization piece that I talked about. Each region has a coordinator. They apply for grants to do education, whatever the region deems that it needs, because we know they're all so different, particularly when you go outside the Atlanta area. The Georgia Trauma Foundation is our fundraising entity that is described in 3111-102 as a mandate as part of that law, that we maintain a foundation to raise funds. And then the State Office of EMS and Trauma. So far, all of the budget areas that I described, I don't want to give you the exact amount of what we're reducing because the commission has not voted on it yet, but each of those, with the exception of the commission operations, has seen a reduction, obviously, because we're trying to sort of go across the board if we can. The trauma registry to support trauma centers, that is a fixed cost. That's something we can't reduce because it's an external vendor that we have to pay to support the trauma centers. And then on the next group, which we consider the Trauma Commission has typically looked at this as a stakeholder distribution, the AVLS support, that is a device that each 911 response ambulance has on it that allows you to track where that ambulance is. So that if there's ever a mass casualty, we know where assets and resources are so that they can potentially be deployed to areas that are needed. And as you can imagine, that's a fixed cost. So then there's also the trauma center, the UCC is uncompensated care claims audit. So as you know, our trauma center funding is divided into readiness and uncompensated care. And there is quite a bit of work involved in validating uncompensated care claims. There's some rules set forward that the claims have to meet certain criteria before they can be paid out. So we have an external agency that goes in and just does a test, and those would be just for the level 1s and the level 2 trauma centers. And then we do provide one of our nursing, or actually our Georgia Committee for Trauma Excellence has an education committee, and they do put forward education requests. That amount is actually above a little bit what it was for FY20, because FY20 we reduced that by 50%. So we hope that we can provide additional education for nurses. And then you can see the bottom there is the basically what's left over after AVLS, the uncompensated care audit, and the nursing education would be split between the EMS stakeholders and then the trauma centers and the trauma physician uncompensated care. And then the next few slides, I don't want to go over them in detail. I think you've seen some of this before. Slides 8 through 12 and 13 really talk about those readiness costs, because that is a huge bucket of our budget. So what are we doing with those readiness costs? And I think where we find ourselves a little bit, the commission finds itself, is that we want to expand the system, but it's very hard to bring on additional funded centers when the readiness cost that we're giving them is about 7 cents on the dollar, and it becomes hard to keep the lights on with what we're actually giving them. So, and if you add to the backdrop of that on slide 15, and I know you've seen, these are two published works that have been done out of the Georgia Trauma Commission, and I participated in these on the stakeholder side of this. A lot of other states are looking at us in terms of what our readiness funding formula looks like. So this has been something that's really been very hard to quantify. In addition to the readiness payments on slide 15, we don't want to be in the business of just giving money. So over the last 10 years, we started with performance-based payments. So in other words, kind of a pay to play to make sure we're sort of leveling out the quality here. And it started in 2010 with only 10% of the readiness costs were subject to performance-based payments, and there were only 3 criteria, and they were mostly participatory. Now they're data-driven, so you actually have to send us reports. They're actually validated by the Office of EMS and Trauma, who's been an excellent partner for us. And so this year, 85% of the performance-based payments are subject to performance-based pay criteria, and there are 15 performance criteria. So we want to be the best stewards that we can of the money and make sure that people are doing the right thing that they need to do. And another, as you saw on the big chunk of the budget, is with EMS education and equipment grants. So the EMS education on slide 16, you can see on the left, we're pretty well penetrated across the state, but there are still areas in white that we haven't been able to get to, and that's where some of the limitations, I think, in funding come, because we want to keep going with courses, but it's really hard to keep injecting money into courses when the budget is a little bit smaller. So we just have to be creative about ways to do that. And this is where we invite our regional folks to come up and give us some proposals for funds. And then the EMS, or the vehicle equipment grants, you can see the map on the right shows you which regions the funds went to. The next slide just talks about our regional advisory committees. I don't need to go through that with you in the interest of time. And then slide 18 and 19 is really where we sit in terms of the evolution of our trauma centers and where we were from 2006 to 2020. And as I mentioned, striking that balance between bringing additional centers into the system. We don't fund all of those 34 centers. Right now, 28 of the 34 centers are funded. So we're doing a study. It's part of our operations budget, which was the slight uptick for this year in the operations budget. A study that we did, it's probably about 10 years ago now, that really shows access, who has access within an hour. And the data that we did, we got about, I think it was 10 years ago, that said that about 80% of our citizens had access within an hour. We want to replicate that because that showed that huge gap down in South Georgia. And we want to see where we are now with the addition of the centers that we currently have. Another big, one of the big pieces that our funding for trauma centers has supported on slide 20 is the ACS Verification, and I mentioned the American College of Surgeons with our system console. This is the mainstay of the American College of Surgeons, is verifying trauma centers. So this is above and beyond state designation. This is a national verification. And to date, 8 centers in Georgia have really stepped up to the plate and gone for this additional verification. And we have put it into the contracts. It's another pay for performance that they will, everybody, level 1s and 2s will be ACS verified by FY23 in order to receive their funds. And then on the next 2 slides, just gives you an example of how achieving ACS verification really drives quality. And the slides that you're seeing are actual risk adjusted performance of Georgia trauma centers compared to the nation. And back in 2017, this data is a little bit, when you get 2017 reports or any reports from the American College of Surgeons, it's usually about 18 months behind. So this shows where we were. You don't have to even know what this means to know that red diamonds are not good. And then when you see the next page, the black diamonds are much better. It means we're reporting at the median, which is where we actually want to be better than that. We want to be green diamonds, which shows we're really good. So I think that it just goes to say that we want to keep investing in this system because it's made a huge difference for our trauma centers. And then I think our priorities with additional funding is really, if we could, if we did have additional funding, is we would look at recruitment of additional trauma centers in the areas of need as defined by the study that we're going to replicate that we did before, to show where we really needed to focus our efforts. We really need to figure out a way to support rural trauma care better and what it means to them, and knowing that is going to help us. 3111-102 describes that we need to do regional trauma transport improvement, and the Trauma Commission's been a little bit challenged to tackle that, as well as injury prevention, but it's a space that I think we're trying to figure out how we get into. And slide 25 is our Trauma Awareness Day at the Capitol. I just wanted to make sure that you're all aware of that, because we certainly would love to share with you what is going on to keep our citizens safe in the state. And I think I'll wrap it up with that if you have questions.
Liz, I've got a question for you.
Sure.
I'm looking at, on slide 19, the map of the trauma centers. And
Yes, sir.
we've talked about this previously with our level 1 centers. In southwest Georgia, we still don't have anything. And if you are injured in an accident on I-75 south of Macon somewhere, your closest center is either going to be in Macon or in Florida, I think.
That's correct. Yes, sir.
How are we doing at establishing, I know there's been some work going on trying to work on doing something like that about establishing a level 1 center somewhere in southwest Georgia down there. Are we making any progress with that?
Yes, so thank you, Mr. Chairman, for asking that question, because we've made a lot of progress with Phoebe Putney to bring them on as a level 2 center. And level 1s and level 2s are essentially clinically equivalent. The main difference is that the level 1 is really the driver behind evidence-based practice and research, but clinically they should offer the same services. So Phoebe Putney has moved forward with their plans. They've hired a trauma medical director. It's very encouraging. They've hired a trauma program manager, so they have the right infrastructure there to move forward. So we hope within the next 12 months that we can bring them online, because they were in that original study, that was an area of defined need, and so it would really help us to bring them on. In addition, we'd like to identify some level 3 centers. So while level 3 center might not get you a subspecialist such as a neurosurgeon or even an orthopedic surgeon, if you can have access to a trauma surgeon, that's really what the differentiator between a trauma center and a non-trauma center is, to be able to have access to a surgeon to get to the operating room quickly if that's necessary, or to get plugged into the system and quickly transferred to higher level of care. So if we could get Phoebe on board as a 2 and then look at target other level 3s, potentially we could really increase our access in that area.
Good, thank you.
Welcome.
Anyone else have any questions? Okay, anything else you want to share with us before we wrap it up? Oh, I'm sorry, excuse me. Representative Taylor has a question for you.
Thank you, Mr. Chairman. You noted that your budget is just under $16 million, but the revenue is 23. Where does that go?
The additional revenue?
Yes.
So, as I mentioned in the 17, 18, 19, and just this last year, we successfully came forward with a case to get some additional funds and were granted some of those additional funds. But I believe the rest of the money is in the general
It goes to
fund.
general funds.
Correct.
Are we using any of that money to help some of the rural hospitals qualify to be emergency centers? That, I mean, I think that should be our goal. We have big empty spots in South Georgia.
So on page 5, the plan, and I believe we talked about this a little bit before, I think it's the most aggressive plan to date with amended funds or any commission funds to look at and inject funding, particularly with respect to the level 3 centers, to do a across-the-board increase in their base funding, as well as support their participation in the American College of Surgeons initiatives, because right now we have no idea really what's happening at those centers. So we want to bring them on board. We want to give them the funding to support their participation in the American College of Surgeons quality initiatives, so that they know what they need, and that would help give us better information about how can we fund you to do well. So, so that is our hope moving
Okay.
forward.
Thank you.
You're welcome.
Representative Gardner has
I have a couple questions, and I'm kind of confused. The Trauma Care Network Commission is attached to DCH, and the Emergency Preparedness Trauma System Improvement is another separate department that's part of the Department of Public Health. Is that right?
Are you looking on slide 7 with the State Office of EMS?
No, I'm looking at our tracking sheet. So,
Oh.
what slide did you refer me to? 7?
Yes, and we're attached to the Department of Public Health administratively, yes. And part of our funding, in 3111-102, up to 3% of our funds go to, the commission has to vote on that annually.
Another question, Mr. Chairman. Sure. Do you know anything about who the super speeders are? What part of the state?
That's a great question. I would love to know a little bit more about that. So far, I haven't been able to really dig into that.
So we don't really have any information?
Yeah. I'm sure the information's out there, but I think that would be a great thing to.
I'd love to know.
Mm-hmm.
It's pretty hard to speed where I live, but anyway.
Okay. Did you have another question? Anybody? How about you? Yeah. Thank you very much. Appreciate
Thank
you
you.
being here.
Thank you for the opportunity.
Thank you. This gave us an opportunity today to hear from some of the agencies that we didn't have a chance to listen or meet with the other day when we did this, and gives you a little more understanding of some of the issues we're going to be dealing with. Any announcements I need to make or anything? Okay. Thank you all for being here. We'll adjourn.